Yeah, thank you. Can you invite the panelists also?
Sure, sir. I will do it for you. So for this panel discussion, I would like to invite panelists Dr. Rajat Bajaj from Fortis Hospital, Noida, Dr. Mudassir Ahmed from Fortis Hospital, Noida. Dr. Mudassir, are you here? Dr. Mudassir. Dr. Sachin Kurana, Associate Professor from AIMS, Delhi. Dr. Sachin. Dr. Sachin, are you here? Dr. Rajit Chana, Medical Oncologist from Dharmashila Narayana Hospital, New Delhi. Dr. Kumardeep Datta, Senior Consultant Medical Oncologist from Fortis Hospital, Delhi. Dr. Samit Purohit, Consultant Medical Oncologist from Action Cancer Hospital, Delhi. And Dr. Kaushal Kalra, Consultant Medical Oncologist from Safdarjung Hospital, New Delhi.
So, who all are there, if I may ask? Dr. Rajat Bajaj, Mudassir, Dr. Rajat Chana, Dr. Kaushal, and Dr.
Sachin Kurana.
Purohit.
Dr. Datta.
I can see it. This is Rajat Chana. So, can I have my slide set? I think Haru Bansal, I've already shared my slide set with him. As a matter of fact, I don't even need the slide set. So, Rajat Bajaj, you're there? I don't think Rajat is there.
Dr. Manish, sir, we have your slides on the screen, please. You can have a look to the screen, sir.
Yeah. Who all are there actually? I could see Rajat Chana. I don't know whether Dr. Kaushal is there and Dr. Samit is there.
Sir, Dr. Kumardeep is there. Dr. Kaushal Kalra is there. Dr. Rajit Chanana is also there. And sir, we can also involve, if it's okay to you, Dr. Venkat is there. Dr. Colonel P. Suresh sir is there. Dr. Nagendra Sharma is also there. If we can involve them.
Fair enough. Dr. Rajit is also there.
Rajat Bajaj is there or Rajat is there? Rajat Chana.
Sir, Dr. Rajit Chanana is there.
Yeah. So Rajat, my first question is to you. What percentage of your patients are able to take the immunotherapy along with chemotherapy in extensive stage small cell lung cancer?
Sir, it's a very tricky question because you don't get to see very large number of patients of small cell lung cancer. So it depends whether they have...
Out of say 10 patients in the last 1 year or last 2 years, so what percentage of your patients are able to take immunotherapy?
So I think if I give the percentage, that would be not fair. I would say that the panel patients, all patients, and those who are not panel patients, none.
Oh, you have the luxury of seeing panel patients also. I don't have that luxury. So so hardly, to my mind, hardly 10%. So we'll go to Kaushal. Dr. Kaushal, what percentage of your patients in Safdarjung Hospital are able to take immunotherapy?
Yeah, I am the same answer, panel patient, 100% of patient. If no panel, then 0% of the patient. Because I am from the Safdarjung Hospital.
So you see a lot of panel patients in Safdarjung as well?
Not a lot of. So many patients are coming for referred. Yeah.
Okay. And who else do we have in the panel? Dr. Kumardeep. Dr. Kumardeep, again the same answer. I don't know. So Rajat, what do you prefer between Atezo versus Durvalumab? How do you distinguish between these two options? These are all two competing standards of care. So what's your distinction?
So I don't really know what is the the best IO. So I have used 2 times Tecentriq and 2 times Durvalumab. So both patients, all the 4 patients, they did well. So frankly, I really don't know which one is the better of the two. I think both are equal and both can be given. So
that's a very realistic answer. Now coming to Dr. Kaushal. Dr. Kaushal?
Yes, sir. So actually,
how do you make a distinction between the two?
The same answer. There is no actually data which is the better, but I have not given atezolizumab in any small cell lung cancer. Durvalumab I have given.
Durvalumab.
Yeah.
So is it just a matter of chance, or you think that Durva is perhaps a better IO as far as small cell is concerned? It's just a matter of chance.
No, it's a matter of chance.
It's a matter of chance.
Yeah.
Dr. Suresh, you made a wonderful presentation. You told us about if you're there. You're Dr. Suresh?
Yeah, I am there. I am there, Dr. Manish.
So how do you make a distinction? Hi. So how do you make a distinction between, you showed us a few data about carboplatin, cisplatin, and the follow-up data up till 3 years versus 2 years. So how do you make a distinction between these two IO agents?
So it would be a theoretical answer actually. Practically, I agree with most of my other panelists that I do not make a distinction. But theoretically, if you have to go by evidence, then atezolizumab does not have a cisplatin arm in its trial. And as far as brain metastasis was concerned, again, untreated brain metastasis was not allowed in the atezolizumab trial. So there is some extra subgroup analysis of brain patients from the durvalumab trial.
Right.
And the fact that cisplatin has been used in the durvalumab trial, maybe when you use cisplatin, you can have
more
more
confidence.
confidence.
Rajat and Kaushal, how often do they use cisplatin and how often do they use carboplatin?
So I use carboplatin for all of my extensive stage patients.
There you go. That's the answer. So Kaushal, cisplatin versus carboplatin.
Yeah, I will also prefer carboplatin. But if PS is very good and young patient, I am preferring cisplatin, whether limited or extensive.
Okay, so fair enough. So mostly carboplatin in extensive stage. That is what you said.
Yeah.
Yeah. So I think the Dr. Suresh, the answer is very clear. Means, is it really a distinction? Means just because cisplatin was allowed, but who uses cisplatin? Means why do we break our sweat on cisplatin versus carboplatin when most of us are using, at least in 90% cases, carboplatin only? And regarding the PCI. The PCI was allowed in the atezo study, and the PCI wasn't allowed in the durvalumab study.
Correct.
So, do you use PCI, Dr. Kaushal?
Yes, sir.
So, if the patient is on durvalumab, what will you do? You not use PCI?
So PCI, I will prefer to go for this thing PCI in my patient.
But PCI wasn't allowed in the durvalumab study.
Yeah, that is true.
So can we conclude that we don't give a damn? So I think it's absolutely okay to give PCI. I don't. Although there is a study, the Japanese study, which showed that PCI perhaps only deranges the quality of life, but that's only in the Japanese population. But I think the consensus is to still use the PCI. I'll go to Rajat. Rajat, do you use thoracic radiotherapy if the patient has extensive stage disease, minimal extrathoracic disease, and has residual thoracic disease after the chemotherapy? So do you use thoracic radiotherapy?
So frankly, I have not used it, but I think there is data that if there is a response and there is only residual disease and only some part of the lung, then I think it should be offered, even in extensive stage.
Yeah. So if the patient is on durvalumab, Dr. Suresh, how do you do thoracic RT instead in case you wish to do it?
Yeah, so there is no evidence as of now to give thoracic RT while on atezolizumab or durvalumab. But for 2 patients, I have given thoracic RT But I did stop both these agents during that time and then continued them later only, because I did not know how bad would be the pneumonitis or the other complications during post-thoracic RT if I use the agent along with the RT. So that is how I did it. So I am, but I think there's no evidence of these using these agents along with thoracic RT as of now.
Right. So, so there's definite fear of using thoracic RT. Perhaps if the patient has done well, yet have some residual disease, I think one would be tempted to use thoracic RT to give that extra benefit. But even I'm not very sure that how do you combine and what are the risks involved in giving thoracic RT. And it wasn't allowed for both the drugs. So any other, Dr. Kaushal, any other concern regarding the IO drug, and what has been your experience of using the IO drug? You have used mostly durvalumab, and since this is AstraZeneca symposium. So what's your experience of using durvalumab?
Actually, 2 of my patients are still continuing on this thing, durvalumab, and they are doing well till now. There's no significant adverse. Yeah, and not much experience with these.
So, Dr. Suresh, I have one question. I have one patient who was on durvalumab, and the patient, had a progression, mild progression in the disease, not an overt progression. What should I do with the durvalumab? Should I continue beyond progression, or should I stop it and switch the chemotherapy? Or should I switch the chemotherapy and yet continue durvalumab? Patient is tolerating durvalumab well. So, and the progression is a very oligo progression, you can say.
So for these kind of progressions, we do not have a specific answer, because there's no data to say that we can continue durvalumab on the same chemotherapy. But if we can extrapolate oligo progression guidelines from any disease, like what we can do, go for some local therapy and SBRT for that oligo progression perhaps, and then try to continue with the same therapy. Perhaps I would think on those lines. But continuing immunotherapy after proper progression, gross systemic progression, along with change of only the chemotherapy backbone, I don't think there is such evidence. So we have to stop the immunotherapy and start him on second line chemotherapy.
Right. We have almost 3 years of data with durvalumab with almost 17% overall survival. Whereas we don't have that long data set with atezolizumab. We have 2 years data set with atezo, which shows around 22% survival. But a 17% survival at 3 years, that means the drop has not been very significant. It dropped from 22% at 2 years to 17% at 3 years, which seems to be quite significant. And it's a very robust data set of long-term benefit, at least in 1 out of 5 patients. Dr. Rajit, your comment on this information.
So yeah, so with a disease like a small cell where the prognosis is really bad, so IO has given at least some hope. And there is, as you suggested, that there is some data that if the patient has responded and has crossed a particular duration of time, then there is still hope that the patient might be having a maintained response if the patient had initially response after probably 6 to 1 years. And based on this data, similarly, we can answer your previous question. So if the patient had mild progression, so it depends on what duration this patient had that mild progression. So suppose it's in the initial phase of the treatment, then we should consider changing it. If it is in the later treatment, then maybe we can give some kind of local treatment and then observe.
So right, I agree that these are the various principles of treatment which I think people do extrapolate and still use in routine clinical practice. And as far as routine clinical practice is concerned, I think there is not much distinction between the two agents. But yes, the volume of evidence and the length of evidence is favoring durvalumab over atezolizumab with 3 years of follow-up as compared to just 2 years of follow-up with atezolizumab. So that way, perhaps durvalumab should be the preferred option. But as such, there is hardly any distinction between the two agents. And lastly speaking, I think we can conclude this panel discussion over here. And lastly is that PCI on thoracic RT, everybody are tempted in a well-responding patient. People do use it, although the guidelines may talk otherwise, but people do use it, and I think it is absolutely okay to use it. And perhaps one may have to stop durvalumab for a while and do the thoracic radiation, and then still continue durvalumab beyond that. So I think these are various modifications that we do in clinical practice based on our clinical judgment call. But overall, yes, IOs have definitely led to improved survival and extensive stage small cell lung cancer. Any other comment from the panelists as we can close this session? Any other comment? Dr. Suresh, Dr. Rajat, Dr. Kaushal?
So one simple comment that the choice of IO will also depend on the sponsor of the meeting.
Right.
Yeah, that is the most important part.
So with that, I think we can close this session.
Yeah.
And
Thank you, sir. Thank you, sir. Thank you, all the panelists, for your excellent inputs. With this, we come to the conclusion of